class, you actually also saw the knee special tests. So we're actually going to go over some of the knee special tests, or all of them actually today. And I'm also going to go over some of the more common mechanisms of injury for the lower extremity or for the knee as well, since we didn't go over those. And then again, if anybody has questions, you should be able to see, it's kind of weird that I'm pointing, but across all the bottom of your guys' stuff, you should see stuff. So do you see that little chat button right there? Yep, exactly. If you guys have questions, feel free to put your questions there, and then we can do our stuff. So actually, it looks like a couple people are already posting some questions. Oh, awesome. You're just answering all my questions. So, but when people post stuff, will you let me know? So here's what we're going to do is, in the very beginning, the first thing I'm going to go over is the most common mechanisms of injury for the knee. And I want you guys in the chat box to let me know which ligament do we think, or from medicine, is the biggest deal for the knee. If you had to pick one ligament that we talk about the most and we think is the biggest deal, which one is it?
You're saying ACL.
Oh, I can actually see it on the screen now.
Oh,
Yeah,
yes.
yeah, you guys are absolutely right. It's totally the ACL. And really, that's the only one that we always do, well, I shouldn't say always, but most commonly do surgery on. And so making sure that you guys understand that, I think, is important, because we don't, the PCL, we heard it sometimes, but not nearly as much as the ACL. And the MCL and the LCL get hurt sometimes. The LCL is way frequent, or infrequent as well. And so I think understanding that is important, and making sure that you guys kind of know how to go through the process of eliminating that stuff. Remember, before I talked about intrinsic and extrinsic ligaments, and that the ACL and the PCL are the intrinsic because they're actually inside the knee joint, and then the LCL and the MCL are extrinsic ligaments because they're outside of the knee joint. So anything that's outside of the capsule makes it extrinsic, okay? And so when we're thinking about that kind of stuff, that's something that I would keep in mind as we're trying to kind of progress through this kind of stuff. And so, actually, give me 1 second. Do me a favor and see if you can make this. Just move on to this guy, and then I can try to put it in there, because I can't get it any other way. All right, sorry. I wanted to see if Leah could get something. She's here to help me. She's going to be my model today, so I can show you guys how to do some tests. But the first thing that I want to show you guys before we get to doing tests is understanding where and how some of these injuries can happen. So when we think about the ACL, and there's going to be some pictures for you guys to see too, but when people are going to tear their ACL, they're going to plant, and typically they're going to come into a cutting motion. So what's happening is they're putting, if you guys remember, valgus stress, they're coming to the inside, but then they're internally rotating their femur and or externally rotating their foot, like it's a planted foot. And so what you're seeing is a little bit of knee flexion, you're seeing valgus stress, and then external rotation of the lower leg. And when we put our knee in this kind of angle, we take that ACL and we put crazy amounts of tension on it. And so because of that, it makes it so that way we're going to tear it. And the ACL and the PCL, when they're in the knee, they're kind of wrapped around each other. And so when you think about that, that makes it so when you put that rotation on it, it puts it on high tension, and it makes it so that way we tear it. Now, interestingly, or maybe hopefully this will help you in knowing stuff, is we use the exact same mechanism for a lot of other things. So that valgus stress, so just coming from the outside to the inside, is how we isolate or only injure our MCL. And we can actually tear our medial meniscus in the same way, because the medial meniscus and the MCL are actually attached to one another. So the outer layer of the medial meniscus and the inner layer of the MCL are actually bonded together, and that's why those two structures tear or are damaged together really frequently. And so when we think about that, think about if one gets hurt, there's a high propensity for the other one to get hurt. They don't always have to happen that way, but it certainly can happen. The other thing to think about is when we're in that kind of position, we can also sometimes cause damage to the LCL, or not the LCL, the lateral meniscus. And why would we be causing damage to the lateral meniscus, do you guys think, in that kind of position? If I'm in extreme valgus stress, why potentially would my lateral meniscus be hurt? You can type your answer into the chat box. Yeah. So we got one vote for rotation, pressure, yep. Okay, what do we call pressure? What is that called? When we talk about pressure, what is pressure? What is our medical term for pressure? Yeah, yep, compression. So when we think about tension, tension is what we're going to experience on the medial side of the knee. So that's why we're going to tear the MCL. And the reason why we might maybe hurt the lateral or the lateral meniscus is because we're actually compressing what's going on the outside. And so that rotation along with the compression can actually cause us to tear our lateral meniscus. Now, lateral meniscus tears aren't as common as medial meniscus tears, just the same as LCL injuries aren't as common as MCL injuries. So just remember, on the medial side, we're just more likely to probably hurt that, okay? And then the other thing that we can do, so we can talk about the ACL, the MCL, the medial meniscus. If we tear those three things together, we're actually going to get something called the unhappy triad or the terrible triad. And there are two terms that are synonymous, and I would make sure that you guys know those. This is something that's not an uncommon injury at all. We actually see it fairly frequently in athletes where they're planning, they're shifting, they're cutting, and then we see them cause damage to all three of them. So again, it's the ACL, the MCL, and the medial meniscus. And no, the unhappy triad and the terrible triad are all the same thing, and they mean the same thing when that's happening. The final injury that we get when we do that kind of stuff is if we had to say which way we're going to most commonly dislocate our patella, which direction is that? So the question was, which way do we most commonly dislocate our patella? Not the mechanism, sorry, the direction that we most commonly dislocate our patella. Yeah, yep, yeah, good, yeah. So absolutely, we typically go lateral. And the reason for that is usually what we see are really tight lateral structures, and then our VMO, which hopefully everybody has learned by now, learning your anatomy, it's that medial muscle. I call it kind of your biker muscle, is sometimes not as strong as it should be. So again, it's the exact same mechanism as tearing our ACL and everything else. Is we're in this planting position and we're going to cut. What happens is these structures are really tight and our medial structures aren't strong enough, and so we laterally dislocate our patella. So it goes to the outside, and then what we normally see is people fall down to their knees in a flex position. They have an externally rotated lower leg and they have valgus stress, and when they fall down, their leg kind of stays in that bent position, and their patella will usually be sitting laterally. Not that you should ever reduce something on site. Remember I said that we don't do that, but typically the fastest way for them to have the greatest amount of relief is to just straighten their knee or ask them to straighten their knee. And what usually happens is the patella will spontaneously reduce. And sometimes it sounds gross because it basically ricochets off the lateral femoral condyle sometimes, but it'll go back into place, so it'll rest between the two condyles, and it will feel much, much better. So if you find them and their knee is still in a flexed position, just tell them to straighten their knee if they can, and typically their patella will go back in place. And so knowing that is something that I think will be helpful to you. So all of those different injuries have the exact same mechanism. From there, we have, I gotta think, what's our next thing? There we go. All right, our next things, oh shoot, I wanted to be able to show you guys this stuff. I don't know how I can do this. We're gonna try it out though. I'm gonna share it with you anyway, but let me see if I can do this. Maybe kind of, almost. So that's the PCL, that's backwards, huh? Sorry, it looks terrible. But what I want you to get from that is notice there are lots and lots of ways to tear your PCL. Most of them have to do with either a hyperflexion. So notice the one way over on the side where they're like kneeling all the way down. And notice that their foot is all the way in plantar flexion. The reason why that's important is because if their foot is in dorsiflexion, it makes it so that way the tibia is locked in place and the tibia can't slide posteriorly because you have to have posterior translation of the tibia for the PCL to tear. Unlike the ACL will tear when the tibia ends up anterior to the femur. So this is something that people sometimes have a hard time learning, and what you need to understand is it doesn't matter if the femur is moving or if the tibia is moving. What matters is where the tibia ends up in relationship to the femur. So if we're standing like this and this is my femur and I get hit on the posterior superior aspect of my tibia, well, my tibia is going to go anterior, so that means that I'm going to tear my ACL. But if I get hit on the anterior superior aspect of my tibia, then my tibia will move posterior and I'll tear my PCL, okay? So again, it just matters where your tibia ends up in relation. So let's flip it around and I want you guys to answer on there. If somebody hits, say I'm standing right here on my tibia, and somebody hits my femur, my distal femur, on the posterior side of my distal femur, which ligament am I going to tear? If somebody hits me on the distal posterior aspect of my femur, which ligament am I going to tear? Type it in for me. So it's going to shove it anterior, the femur. Okay, watch what I'm going to do. The tibia is my bottom one, right? And the femur is my top one. So if they hit my femur on the distal posterior aspect of my femur, this way is anterior, this way is posterior, it's going to hit and my femur is going to move anterior, right? So where is my tibia in relationship to my femur? Is it anterior to it or is it posterior to it? It's posterior, so that means I'm going to have to tear my PCL, absolutely. Because notice, if I can hear, stand on that side. So if I'm here and say I'm standing on my tibia and Leah comes behind me and she hits me in my posterior side, what's gonna happen is my tibia is gonna stay in place and my femur is going to move anterior to my tibia. Well, if my tibia is posterior to my femur, then I had to have torn my PCL. Does that make sense? Conversely, if she stands on the opposite side and I'm standing on my tibia and she hits the distal anterior side of my femur is going to move posterior, but that means that my tibia is still in the front. It's anterior to my femur. So what am I going to tear? Yeah, yep, absolutely. So don't think about which way they're necessarily moving. Think about where they end up in relation to one another. Because if you're only thinking about the direction that the bone is moving, it's gonna flip depending upon which bone it's moving. So either way, the tibia prevents anterior translation, so it shouldn't be anterior to the femur, and the PCL prevents posterior translation, so it shouldn't be posterior to the femur. But it doesn't matter if the femur is moving or if the tibia is moving. Either way, that's what you're looking at. And then the special tests that you're gonna do are gonna be moving in the exact same direction, because if the ACL is supposed to prevent anterior translation, then the tests that you're going to do are going to anteriorly translate to assess the ACL, and then they're going to posteriorly translate to assess the PCL, okay? So anything that's gonna make the PCL go posterior, that's what's gonna happen. So that's why falling on your knee with a plantar flexed foot, like so, it allows your tibia to move posterior, so that's how you tear it. If you land with it like this, what we actually usually see are high ankle sprains that happen, because what happens is the knee's locked in place and the ankle is what gets messed up. And so think about the difference, know the difference in foot placement and how you're falling. And then also we can tear it from getting hit in the lower leg as well. So if we get a direct blow right there, then we can tear the PCL too. Then the next thing, we already talked about the LCL. So what kind of force are we going to experience when we're going to tear the LCL? And we talked about this in class the Friday the 13th, right? That was our very last class. So what type of stress to the knee do we get that tears our LCL, our lateral collateral ligament? Yep. Yeah. So when we think about what we're doing, we're going to have varus stress and valgus stress. Varus stress is coming from the inside going out, and valgus stress is going from the outside coming in. Varus stress doesn't happen very much because typically when we're cutting and turning, we go that way. Going out isn't something that we do very much unless we're falling down. So that's not something we worry about very much, and we don't often see LCL injuries, at least not very much compared to the other. And then when we think about dislocations of the tibiofemoral joint, usually we see them when people are stopping abruptly or something really bad happens. So one of them that I had to treat was a receiver in football, a wideout who was running, and he kind of like slowed down to see what was happening behind him. And the DB came up and grabbed the back of his collar and yanked him back, which, by the way, is illegal. It's called horse collaring, and you're not supposed to do that, because what happened was when he did that, he stepped and he was planted on it, and then his femur shifted posteriorly, and he completely dislocated his tibiofemoral joint. And it was disgusting. He tore pretty much everything in his knee. He tore his patellar tendon, all of his ligaments, both menisci, and he actually caused damage to his peroneal nerve. And one of the things that I want you guys to know about the peroneal nerve is it's in this posterior lateral compartment of the knee. And it's really important because it comes down and it runs to give innervation to all of the muscles, or most of them anyway, in your anterior compartment. So if you're going to be contracting the muscles in your anterior compartment, what kind of motion will they do at your ankle? If we're talking about the anterior compartment, what kind of motion do they do in your ankle? So one of the things that I want you guys to remember, a lot of people are putting flexion. We have two types of flexion in the ankle. So remember, we have just what we call flexion in the elbow and the shoulder and the hip and the knee and everything else, but we have two specific kinds in the ankle. We have something called dorsiflexion and we have something called plantar flexion. So which one of those two is going to happen at the ankle when we affect the anterior compartment? Yeah, exactly, dorsiflexion. So they're not going to be able to bring their foot up because they now have caused massive damage to that nerve. So what happens is they get something called drop foot. So they are no longer able to bring their foot up. So when they walk, they can't do normal gait because their foot would drag. So as they're walking, so as they walk, they have to hike their hip because they can't dorsiflex their foot anymore, which is not awesome for them, and it causes lots of complications. And so what we end up doing is putting something called a posterior splint that goes inside of their shoe. Usually it's plastic, and it's form fitted to them. So it goes inside their shoe in here. So what it does for them is it keeps them in neutral, which is great. But the problem is they also can't plantar flex, because it's not that they have problems plantar flexing. They can do that just fine. So they can push off, they just can't dorsiflex. But those splints prevent them from plantar flexing as well. So typically we see alterations, even greater alterations to their gait because of that. But it at least makes it so their foot doesn't drag. And the problem with the foot dragging is we tend to trip, because then you catch your toe on a lot of stuff. So then they can get lots of additional injuries because of that. Okay. All right. So now we're going to go into the different special tests. Leah. Hopefully everybody remembers Leah. She is volunteered to come in, which is awesome. Yeah, we're going to be on that table. All right. And I think let's maybe move to the front side of it. Yeah. I'm going to try to make sure that I'm out of your guys' way of being able to view stuff as best as I can. Let me see if I can get it over a little bit. There we go. Okay. When you're looking at your stuff, I'm going to get my computer real quick so at least I can see what I had on your guys' slides to kind of look at, so I can kind of keep in order a little bit better. Maybe. And I know that again for the 8 a.m. class, we kind of went over a lot of this stuff. One of the things, and the good thing is Leah's kind of short, so she can lay down a little bit better on the tables than other people. But remember, we always want to test the uninjured side first, and then we would test the injured side, so that way the patients know what they should be experiencing and how it should feel first. So, and that way you can also gain their confidence. I'm always going to only do it on one side, so that way you don't have to watch me do it twice. But just remember that you should always test everything bilaterally and always do it on the uninjured side first. So that way you have a comparison to see what's going on. And when I did that in class on the 13th, you guys saw me do that on both people, or on both sides of the people that I was testing. And sometimes I could tell that there was a difference between right and left, or sometimes they're like me and they just have really bad like joints or ankles. And so then it just was lax in both sides. So it didn't really matter very much. But the first test that we're going to do is going to be for the knee, so the varus valgus test that we're going to have. And again, between the LCL and the MCL, the most common one that we're going to injure is going to be the MCL, which is going to be on the inside part of your leg. And so the first thing you always do is observation, right? Remember, you have to still go through your hops. And so when you think about that, we have history, so we're gonna ask all the history, then observation is watching her walk in, is she limping? Does she have swelling anywhere on her knee? Is there discoloration? Can I see obvious deformity? Because maybe she didn't walk in, maybe I was at her football game and I saw her get tackled. Can't you tell Leah would play football? She's like 100 pounds. She's a mad tackler, but so I would look to see what happened. If I saw the mechanism, that's great. Otherwise, I would get the mechanism in her history and then come through, and then after I do my observations, I would do my palpation. So I would want to make sure that I touch on the different structures, and she would have already told me what hurts, because I would ask her exactly what hurts, where does it hurt, what does it feel like. And one of the things in this chapter that you guys should have started to learn is the PQRST acronym. Make sure that you understand the PQRST acronym. That's something that you're going to need to know for the remainder of the semester. And if anybody has questions about it, make sure that you let me know, okay? But when we look at this, we're gonna come in and we would palpate and see if the muscles feel squishy like they're supposed to, if her patella feels hard, you know, what the ligaments feel like, if she's going to be talking about any pain, if she has swelling in her popliteal fossa. So this part right behind her knee, kind of that squishy part that sits between your two hamstring tendons, that little space is called your popliteal fossa, and you want to touch in there. It should be soft if it feels really tight. Probably they have some intercapsular swelling, and they maybe hurt some of those big ligaments in there, or she caused damage to some of the muscles in the back. And so that's something to think about. Don't forget that the calf muscles, so we have these gastroc heads, they also cross the knee. From the lower leg, these are the only two muscles that actually cross the knee joints. Now, a lot of the muscles from the upper leg cross down, but from the lower leg, the only two that cross up are your medial and lateral gastroc heads, which is something that I think is important for you guys to recognize, because they do assist with rotation of the knee. So if I'm going to contract my lateral gastroc head, I'm going to externally rotate. If I contract my medial gastroc head, I would internally rotate. And then we'll talk about the hamstrings and how that does that as well. And so I would be palpating on things, touch her patellar tendon to see how that feels, and her tibial tuberosity, and figure out what hurts and what doesn't hurt. And then based upon those things, I would figure out what types of tests I need to do. And also thinking about what her mechanism was and what she said. And so it's not always that I have to do all of the special tests, because a lot of times they're not all necessary. So you really just want to do the tests that make the most sense for somebody. So if she would have told me that she planted and she was going to cut, then I would be thinking probably MCL, medial meniscus, ACL, and potentially a lateral meniscus, just to try to figure out what's going on with her. So I want to especially do those tests to make sure that I'm figuring out what of those particular structures are injured. So remember to do the valgus stress test. We need to put our hand on the lateral side of her leg. We need to stabilize her tibia, and then we would apply a valgus stress. So is there enough room to lay down? Yeah. Awesome. Okay. So the way that we do this, and then also remember too that when we do this, that there's two ways to test it. If we test it in 0 degrees, so in very straight extension, I'm going to be assessing the capsule. Does anybody remember what degree I need to put her knee in to assess the ligaments? Awesome. Good job, guys. Yeah, for sure. So the way that I'm going to do this is, again, I'm going to hold on to her leg, and I'm going to take this, I'm going to stabilize here, and I'm going to use my hand to apply that valgus stress. And at the same time, I'm going to kind of lean my body with it and see if it opens up. So now I'm assessing the capsule, 0 degrees. And then when I go to 30 degrees, so I bend her knee a little bit, and I need to make sure, remember, that they have to relax, they have to trust me, that then once I come to 30 degrees, then I do the same thing again, and I look to see if it bends. Now there's a couple different ways. I know the picture in your book had it so that way the leg was hanging off and they were moving the lower leg. There's lots of different ways to position people to do it, but just remember, if it's at 0, so if it's straight, we're assessing the capsule, and if it's at 30 degrees, we're going to be assessing the MCL. And then the flip side of that, just to double check and make sure, I can do varus stress. So again, 0 degrees, flip my hands around. So now I'm over her MCL, and I'm going to be assessing the LCL or the capsule, and I bend to 30 degrees, same thing. And now I'm assessing her LCL. Can you guys see in the video how her knee, like it's moving, but it's stopping really hard right there as I do that? Yeah, that is normal. Remember when we talk about end feel, what we should see is and feel a nice hard end feel. If there's a good hard end feel, they don't have damage to it, or if they complain of a little bit of pain with it, they might have a grade 1. When we feel a little bit more motion and they're complaining of pain, but it still stops, that's the grade 2. And then, pardon me, for a full grade 3 is when it's really going. And remember also, they may or may not complain of pain when we do a grade 3. And why might they not complain of pain with a grade 3? Yeah. Yep, yeah, because remember, if you tear it really well, then what happens is you also tear those nerve endings. And if you don't have nerve endings, then it's not going to hurt anymore. So it'll hurt initially when you first hurt them, but then eventually we're not going to have pain in it, or the pain that we'll get are going to be from other things. So when we do those two, varus valgus, remember 0 and 30 degrees when we do it. Then from there, the next test that we would do is to assess for her ACL. The #1 best test that we have is called the Lockman's test. It has the greatest sensitivity and specificity. That's something we talked about in another test, but basically, or in another chapter. But in a nutshell, sensitivity and specificity means, is it good at identifying something that's wrong when it is wrong, and also ruling out something that's not there. So it's really good at telling us when the ACL is torn, but it's also really good at telling us when the ACL isn't torn. So you want something that has high of both. So the way that we do that again is we take the knee and we want them to be really, really relaxed, and we bend it between 15 and 30 degrees. We don't want to go all the way up like super high. We want it to be nice and open. And typically, again, 30 degrees is our best position to put them in. And then what I'm going to do is I'm going to stabilize her femur, and then I'm going to take, I'm going to flip my arms around so that way you guys can see. Sorry, you guys can't see what I'm doing. Go ahead and relax for me now. I got you, I promise. So what I would do is I would stabilize her femur, and then I'm going to take her tibia, and I'm going to translate it. You guys see how it's moving? It's going straight up to the ceiling. So when we do translation, we're just sliding it straight. So all we're doing is coming straight up, and notice it's stopping really hard. She doesn't have any laxity in there. And so that's what we're going to do. That is a Lockman's test. And one of the things that you want to make sure is that their hamstrings are really relaxed, because if their hamstrings are tight, they're actually going to pull their tibia posteriorly, so you're not going to see any slide on it. The second best test that we do is called the anterior drawer test. And so if we're doing the anterior drawer, notice the name anterior is in it, so we're going to be assessing the ACL, okay? Because it's the anterior cruciate ligament, not collateral, cruciate ligament. So again, we put them in position. I put right where I find the joint line. If you touch the joint line that you guys have in your own knee, you should feel your femur, and then you come down and there's like a space kind of, and then you hit bone again. So you want to feel where that space is so that way you know you're below it. And then what you're going to do is you're just going to, again, anteriorly translate that tibia, and you're going to look to see if you can feel any motion compared to the other side, so bilateral comparison, and then see if she reports pain. The opposite side of that is the posterior drawer. What ligament are we assessing with the posterior drawer? Yeah, because it has the name of it in it, right? So absolutely, PCL. So we're here. Again, we just put our fat pads here on the anterior aspect of her tibia, and we're going to push straight backwards. So we would do the same thing and push back and see if there's any slide. And if there's no slide, we're totally good and we don't have any problems, so we're happy about it, okay? Well, I assume that she would be happy about it. I hope that she would be happy about it. All right, so then we have the anterior and posterior drawer test. Then another PCL test that we see is the posterior sag, also known as Godfrey's test. So the way that you can just start with that test is having them just lie with their legs kind of like this. And if the PCL is torn, honestly, you might already see kind of the side that you think is hurt, where the tibial tuberosity is sitting a little bit posterior to the other side. But the other way that you can do it is ask them to really relax, and then you put their feet like this, and you will definitely, if they have no PCL, what you will see is that their two tibial tuberosities aren't aligned, and the one that's injured is going to be sitting back. The other thing that you can do to look for tears either in the PCL and or the posterior corners is to add rotation, because as you do this, what you'll see is if they have a tear in one of the two posterior corners, they'll sag more as we do that rotation. So adding rotation to the sag test, also known as Godfrey's test, helps you identify if there's actual capsular tears in either the lateral side or the medial side of the posterior knee. Then from there, we have some of our meniscal tests. And the first one we're going to talk about is, because she's in this position already, which is, hopefully everybody knows by now, is supine. And it's called the McMurray's test. I will lead with meniscal tests by saying they are all atrocious, and they have very, very low sensitivity and specificity, meaning that they are terrible at telling us if you actually have a tear, and they're also terrible at telling us if you don't have a tear. So it's kind of a lose-lose either way, and your best way to really tell if somebody has a meniscal tear is through their history and finding out what causes them problems and what their mechanism was. But also, it's good to do these tests just in case. So what you would do is you would take their leg and you leave them in supine, and you're going to grip their heel. And what we do for this test is it's kind of like a grind test almost of your patella, but instead you're going to be taking them and you're going to rotate their lower leg into internal and external rotation, okay? So that's important, because if we go into internal versus external rotation, we're going to be either focusing on the medial or the lateral meniscus. And then we're also going to add moving her hip into AB and adduction with varus and valgus stress. And as we do this, so if I am out here in abduction with varus stress, what I'm putting compression on, because that's what I'm looking for, is compression, not tension for this. I'm going to be assessing the medial menisci, and depending upon if I'm in internal or external rotation, that's where I'm going to be hitting the different groups of, flexion and extension are going to hit the posterior and the anterior horns. And then if I switch and I go into adduction with valgus stress, I'm going to be now compressing the lateral menisci. And so as I do this, this is how I would assess those. And what I would be looking for or feeling for is a pop or a catch or giving way, and also for her to tell me that she's feeling that as well. Because it might be where I don't feel it, but maybe she feels it. And so when we do McMurray's test, that's what we're feeling for, okay? And you would do it on both sides, but that test allows us to test the anterior and posterior aspects of both of the menisci. And then the next one is the Apley's compression and distraction test. So I would have her flip over on her stomach. We're going to switch injured legs. Now we're going to pretend that this is her injured leg. And what we do is there's the compression version first, and you always do the compression version first. So basically it's very similar to doing McMurray's, except for they're on their stomach. And what you do is you stabilize their femur, and then you kind of do that same sweeping motion where we're going to be moving the lower leg into either varus or valgus stress. And then at the same time, though, for the compression test, we're actually pushing down because we're trying to make the tibia press into the femur, so that way we can figure out where maybe that happens. And she says, oh, right there, that's where I have pain. I would say, okay, so the compression test, I'm pushing down and that's what I feel. So what I would do is I would flip my hands around. She's still saying, yep, pain, pain, pain. I would flip my hands around and then I would do the distraction test, meaning that I would pull up. So I'd keep it in the exact same position and pull up. And if that alleviates her pain, then that's a pretty good sign that she probably has a meniscal tear. If it doesn't alleviate her pain, she could have a meniscal tear, or she could have some kind of soft tissue thing or a lot of swelling in her joint. But that's kind of how the Apley's compression and distraction tests work together in concert with one another. And then go ahead and flip over on your back for me again. The last couple that we're going to talk about are the patellar tests. And so when we do the patellar test, there's a couple different ones. The first one that I don't think it's in your book, but I don't know that it was in your PowerPoint, is called the ballottement test, meaning a ballottable patella, starting with the B, is one that think about buoyancy, something that's floating. So your patella is basically floating on a lot of fluid. You have a lot of swelling in your knee. So what happens is if somebody has a ballottable patella, if you push it down and then you take your finger off of it, it will bounce up. That's what ballottable means. So if you push down on the patella and then let it up, it's going to kind of rise back up again. If that happens, you know that they have a lot of swelling in their knee and probably have injured a fairly big structure. It can also happen sometimes if people have a bursal injury. So if you have, remember in the book and in the PowerPoint, it says you have about 20 or so in and around your knee. And again, they're all there to help against high friction forces, but also from big acute impacts. And if you hit the one that's anterior to your patella, you can get really massive amounts of swelling around the anterior aspect of your patella. So the same thing can happen. One of the tests, you can also do like a grind test where you kind of push it down. And I will tell you right now, always do that test on the opposite side because it does not feel good to have your patella ground down into the femoral condyles underneath it. Most people are not a big fan of that particular test. Another test that we can do is you actually take, and again, this is a test that you need to do on the opposite side, but you take your hand like a horseshoe and put it over the superior portion of the patella and don't push very hard. You push lightly. And you say, okay, I want you to contract your quad, and you do, and then you say, okay, relax. And then you push a little bit harder, and you say, contract your quad, and then relax. And then you push again, contract your quad, and relax. And if they start complaining of pain or you're getting crepitus and stuff, then that's what we're looking for something along the lines of chondromalacia or some kind of maybe osteoarthritis on the posterior aspect of your patella. By the way, I hate the term chondromalacia. It's kind of a BS term that doctors often use when they don't know what's wrong with your knee. The technical definition for it is that you have softening of the cartilage on the posterior aspect of your patella, and sometimes you have some chondral defects in there, but it's kind of like when people tell you you have shin splints. It might be that, but there's usually something else going on. And then the last one is doing the patellar apprehension test. And we'll talk about apprehension tests in other part of the body as well. But this is what you use if people have a patellar dislocation or you think that they potentially subluxed or dislocated their patella. And what you do is you just take your hand, or even just your thumb is all I ever have to do, and very gently, not quick, nice and slow, start applying lateral pressure to the medial side of their patella. And as you're pushing it, you guys should be able to see, like, notice how her patella is moving as I do that. Watch how it's normal. And I start pushing and pushing and pushing. Can you see how her patella is moving laterally like that? If somebody has subluxed their knee, by knee I mean patella. Sorry, I didn't mean to say knee. Patella. If they've subluxed it or if they've dislocated it, what are they going to do?
Like tighten up and guard against it.
Yeah, they won't like it. It's called apprehension. When you're apprehensive about something, that means that you're nervous about it or you're scared it's going to hurt or something. So almost as soon as you start pushing laterally, the people are going to squeeze their quads. They're going to be like, nope. And that's gonna prevent it from moving. And if they start squeezing their quad, when you start pushing, that's a positive apprehension test, and you should be highly suspect of somebody having dislocated their patella. Because it might be in place if you're already in a clinic, or I had a girl who had torn her ACL, came all the way back from it, was playing in a soccer game the following season, on the bench from over half the field away. We heard this gross sound, and she fell straight down and started crying almost immediately because she thought for sure she tore her patella. She did not tear her patella, but she dislocated her patella, or didn't tear her ACL. She dislocated her patella, and then it spontaneously reduced because when she fell down, so she was in this position, she was cutting, which is the perfect ACL or unhappy triad, but it's also how you dislocate your patella. So she did this, and when she fell down, it dislocated, and as she was falling, her knee straightened, and when her knee straightened, when she fell down, her patella spontaneously reduced. It went back into place. So when we got to her on the field, we're like, oh, you maybe tore your ACL, but you're guarding so much that we can't pick up on it. No, when we took her in for an MRI, she had torn all of the medial structures, like her MCL and her fascia and her everything. She'd actually caused some damage to her patellar tendon. And her IT band was crazy, crazy tight. So that is the only time, like, she had no MCL left, basically. It's the only time where I've seen somebody go in for an MCL surgery just to fix the MCL. But she wouldn't have had any medial structures left if we wouldn't have done that. So kind of crazy. Anyway, that is all the knee tests. It's 8:50,